Hi there, my name is Chris Malkin. I'm an interventional cardiologist and I'm based in Leeds. I have a major interest in structural valvular intervention and I've been practicing for around 10 years. My team and myself do several hundred valvular procedures a year, and we're considered experts and pioneers in some fields of interventional structural management and research. Hoping to talk to you this morning about valvular heart disease, and we'll start with some very simple themes and work on to how perhaps you might need to see someone like me and have treatment. Valve disease is a group of conditions. There are 4 valves within the heart, and they all have specific important jobs to do. But in general, their job is to direct the blood into the heart and to allow it to circulate through the heart and out to the body. By and large, the problems with heart valve disease are either the valve becomes thickened and restricted and doesn't open very well, such that the heart has to work harder to push the blood through that heart valve, and therefore the heart has to work harder overall. Or the valve leaks, either because it's damaged or because its support structures are affected, and that causes extra work, and the heart has to overcome the leak that is on top of the normal cardiac output. In adult populations, typically we are dealing with heart valve problems on the left side of the heart. That's the aortic valve and the mitral valve. Both of these valves, when they're healthy, are very thin, compliant structures. The aortic valve separates the heart from the rest of the body. It's a very important structure. All of the blood that goes out of the heart goes through the aortic valve. If the heart valve becomes narrowed, it causes extra pressure work on the heart, such that the heart essentially gets tired. And as time goes on, the heart falls into what we call heart failure. And the patient with heart valve disease will become breathless. The other valve on that side of the heart is the mitral valve. That's actually within the cavity of the left heart. This valve, it typically goes wrong, is caused by leak. Either the structure, the cords supporting the valve become damaged or stretched, or the valve leaflets itself become floppy, such that it opens at the wrong time in the cardiac cycle, meaning that blood is going backwards through the heart rather than forwards and out through the rest of the body. So heart valve disease is a group of cardiac conditions that require, each valve requires special interrogation with techniques, and each different valve often requires different strategies and treatments to potentially solve the problem. The most likely way that a patient will know they have heart valve disease is with one of these. It's a simple stethoscope. It's something that every doctor and GP will have in their desk somewhere. And as the blood goes through the heart, their heart generates specific sounds. This is the classic lub-dub that you will be aware of a heartbeat. But if there's a heart valve problem, what that generates is turbulence or high flow through the diseased valve. And a doctor or a trained nurse listening to the heart can hear this extra noise, and that would be called a heart murmur. Now, not all heart murmurs are serious. Some people have heart murmurs and it's entirely benign, but a new heart murmur or a heart murmur combined with symptoms would always mean that you should be seen by a doctor and often referred on to a cardiologist for assessment. The next key step in evaluating heart valve disease is what's called an echocardiogram. This is a kind of like the baby scan that you would do in a pregnant lady to look at the baby. We use ultrasound to assess the heart through the surface of the chest. It's a non-invasive test. And we can examine the heart valves and the heart structures themselves. And we can measure the speed of the blood and the pattern of the blood as it passes through these heart valves. And we can, with great accuracy, determine whether the valve is leaking or whether the valve is narrowed, and indeed how bad that leak is and how narrow that valve might have become. It's also important to assess how the heart valve disease is affecting the heart. If you've got a narrowed heart valve, often that means the heart has to thicken up as it becomes stronger to have to deal with the particular narrowing, so we will measure that. If a heart valve is leaking, often the heart will stretch or swell, to accommodate for the extra work that it has to do. So a typical echo will take 30 to 40 minutes and you'll get a result almost straight away. It often requires a degree of interpretation, and that would be taken into account with other tests. The other more, if you do see a heart specialist with symptoms after the echocardiogram, there's a number of other tests that may or may not be required. The first is an invasive angiogram. That's where we're putting a tube inside the heart, usually from the wrist. We're measuring the pressure within the heart. We're looking at the blood supply to the heart. We're looking at how the valve is affecting the rest of the cardiac structures. Secondly, a CT scan. Typically, this is to evaluate whether you can be treated with a keyhole TAVI valve, something that I'm particularly expert in. That will determine how and whether a TAVI aortic valve can be implanted without open heart surgery. And finally, what's called a transesophageal echo. That's particularly to look at the mitral valve, the other valve in the left heart. This is a very complicated structure of the mitral valve, and we often need to look at it from a different perspective. In this study, you will come into hospital for 2 to 3 hours. We often give tiny amounts of sedation, and we'll ask you to swallow a probe on which an ultrasound is mounted, and we can look at the heart from inside the body. We get really fantastic pictures of the mitral valve to determine whether it can be repaired, potentially by a surgeon, or repaired with so-called keyhole techniques, typically something called a mitral clip or a Pascal clasp. So as I alluded to earlier, not all heart valve disease is serious or dangerous. And in fact, most heart valve disease doesn't require any specific treatment. It often does require surveillance. The main reason that treatment will be recommended is if the heart valve disease is either causing you symptoms. The most common symptom is breathlessness. The next most common symptom is either fatigue or chest pain, dizziness, lightheadedness, occasionally blackouts. Sometimes people don't have symptoms that are obvious, but we can see on the heart scans that the heart is beginning to struggle. And that's why we do keep an eye on patients with heart valve disease, and we often repeat the echocardiograms. Even though we know that a heart valve, say, is narrow or is leaking, we're interested to understand how well the heart is coping with that heart valve disease. If we see that the heart is beginning to stretch or swell or become weaker, then that will be an indicator that the heart valve is now causing a problem, even in advance of symptoms, and we would often recommend treatment. Finally, we often do provocation tests. Again, if patients have serious heart valve disease, but no obvious symptoms, we may ask them to walk on treadmills so we can monitor their ability to exercise, check how they respond to blood pressure, and to check how the ECG and heart responds to the physiology of stress under supervision. Investigations are principally to determine how bad the heart valve is, whether it can be treated, and finally, should it be treated? And often there are different treatments available. You will likely see a heart specialist, a cardiologist like myself, and you may also need to see a heart surgeon, someone who does open heart surgery. And there are a wide range of other specialists who may support these individuals, and that's called the heart team. Many patients might be suitable for both treatments. If we just talk about aortic valve disease in the first state, open heart surgery had been the gold standard of therapy for many years, but increasingly keyhole valve surgery, so-called TAVI, T-A-V-I, is increasingly effective. And indeed, if you're over the age of 75, we would almost certainly recommend TAVI for you up front if it was felt to be suitable and appropriate. You've got mitral valve disease. It's a more difficult problem to treat with keyhole valves, but can be done, but still surgery is probably the preferred treatment. So once the tests have been done, a group of experts like myself and my team would meet. We would examine the imaging very, very carefully. We would feed back to the patient and the family what we felt is the preferred option. And we would then ask you to see the person who was going to deliver the treatment, either the surgeon or the structural interventional cardiologist like myself, to explain why the procedure is being offered, what the potential risks, and of course what the benefits are. Ultimately, the patient is in charge of their own care. We can only give advice and give recommendations. The patient has to feel like they're in control of the situation, and we will make every effort to do that. The treatment falls along the lines of medication, tablets, of which I have to say they are relatively limited. You can't correct a valve heart problem with medication, but you can affect the way the heart deals with the extra stress. Many patients with serious heart valve disease will be on diuretics, which reduce fluid congestion and to a certain extent reduce the pressure in the heart, and therefore they relieve breathlessness. Often heart valve disease is associated with disturbances in the heart rhythm, and typically people with irregular heart rhythms, atrial fibrillation, for example, will be on anticoagulants. They don't necessarily make you feel better, but they significantly reduce the risk of stroke, which might otherwise cause problems. The treatments fall into open heart surgery. That's where a cardiac surgeon will operate on the heart, removing or repairing the diseased heart valve and putting in either a new heart valve or a repaired valve with an extra ring around it. That's a major procedure. You would be in hospital for at least a week. It would take some months, depending on how you were beforehand, to really feel well and fully recovered. And then there are keyhole techniques. So in the aortic valve, TAVI has become, in many ways, the dominant treatment, certainly in patients over the age of 70 for patients with aortic stenosis. That's where a patient is treated awake, breathing, with a beating heart, but with keyhole techniques, typically implanting a new valve from the groin. And there are mitral valve techniques, which are non-surgical but keyhole. Often these actually do require you to be asleep, but again, the heart is beating and the valve is treated with clips or clasps to bring the valve together and to prevent the heart valve leaking. They are complex treatments. You will need help and advice from the nurses and the doctors to help you understand what is being proposed and why it's being offered. There's never any rush really with heart valve disease, and you and your family should feel comfortable with the information that you're getting from the team who have been treating you.